That's all good. All right, so 65-year-old male, worse vision, had a history of uveitis, surprise. 15 years ago, got better with treatment. Last 9 months, worse vision in the left eye. Treated with topicals, then oral, and now has received a couple periocular injections and has recurred and worsened. Those are steroids that go around the eye, Nathan. That's a periocular steroid injection. That's what the patient looks like before they see me. That's what the patient looks like 3 weeks later after they receive the periocular. Do you want me to ask questions? Should I ask the panel what they think?
Syphilis.
You think syphilis?
But you did the steroid injection?
No, somebody else did. This is now coming to me afterwards.
I mean, I don't do uveitis, but I know that's bad.
Ladies and gentlemen, Peter Kaiser. Peter Kaiser says it's bad. That's great. Good for you, Vader. Nice job. All right, so Peter Kaiser says it's bad. What else do you think, Peter? Should we do something about this?
I would think I'd want to rule out an infection.
Good job, Peter. Excellent. So I looked at the old records, and the patient had an elevated toxotiter. His IgM was negative, never treated with toxoplasmosis. So I treated this patient with Bactrim, and then I actually gave him intravitreal clindamycin because I was concerned about worsening toxo infection. So let me show you how great of a doctor I am. Just wait for it. There you go. 1 month later.
So Sunil, do you use Clinda a lot now? Like,
Do I use clindamycin a lot? When somebody has received steroids around the eye and I think they have toxo, I use Clinda in the eye because I think it inactivates. One of the few things that can inactivate toxo very well. And patients who are intolerant of oral medications, there's a very good data on clindamycin's utility in toxoplasmosis from South America. So I use it in some patients. 1 milligram, either 1 to 3 injections spaced apart by somewhere between 1 to 3 weeks each.
So do you think that's more effective than using triples?
I think it's very effective. I couldn't tell if it's more effective. I do think the nice thing is I know the patient's getting it because I think sometimes it's hard to take triple or clindamycin orally. So for patients who are intolerant, I know they're getting it.
It's also great in pregnant patients who can get toxo flare-ups.
Absolutely, yeah, absolutely.
Sulfa.
So Nathan, do you think this is worse or better?
It looks awful.
Good job, excellent. So what would you do at this point, bro?
Probably a vit biopsy.
You do a vit biopsy?
Yeah.
You always want to do surgery, man.
That's
I mean,
right.
what's this?
Surgery
Are you getting? The patient does have insurance.
You would remove the Myra gel.
I would ask about cosmetic fillers. Always a good idea. All right, so here is my plan. So I gave an additional Clinda. I did an AC tap. Tox with PCR was negative. All the rest of the workup, including FTA, ABS, was negative because we always think about syphilis, unchanged. And so I scheduled him for a vit biopsy. And actually, Nathan had just graduated, and the patient was so upset that Nathan couldn't do it, he decided to fall and then developed a subdural hematoma. So I couldn't actually do the surgery on him because
So
he was.
how often does that happen?
That people leave and fall?
Let me finish.
Yeah.
Toxo IG is positive.
Yeah.
PCR is negative.
Well, if they don't have toxo, so I have an AC tap, so vitreous taps are better for toxo. It's not necessarily always negative. And toxo IgG doesn't necessarily mean that they have active toxo. If they had IgM was positive, I'd be a little bit more suspicious. But the toxo IgG was so elevated, I was concerned about it. So I'm still not sure what's happening here. So that's why I thought a vitreous biopsy would be good. So surgery was delayed, and I'm going to show you the ultrasound, I promise. That's the ultrasound. As the patient, I can't do anything because they still have a subdural hematoma and anesthesia won't clear them. So patient, I promise you, here's what they look like. Again, any thoughts? Go in the eye, right? Fantastic. So finally they're cleared, biopsy is scheduled, and this is what the patient looks like the day of surgery.
Beautiful.
What do you see, Peter?
The cornea is still clear. I mean, that's
The cornea is clear. Well, that's Dante's AC exam. It's like cornea clear. I don't care about anything else. Anything else that you'd notice there, Dante?
Yeah, there's something red inside. Yeah.
Something red, and it's not the Cabernet.
It's not good. It's not that good.
The patient does not have herpes. Now, if you ask the patient, they'd say, I don't know what herpes is.
But at
they
this
don't.
point, you must have gotten back a bunch of systemic lab values.
All labs are, everything else is negative.
And the MRI scan of the brain?
MRI scan says subdural,
but nothing
subdural,
else.
Nothing else.
Nothing
Yes.
else.
You did AC-PCR for herpes?
AC-PCR, also negative, yes. Awesome, good. You guys are awesome. Good job. All right, so helpful.
Fake cased.
Fake case? All right. that's actually one of Peter's post-injection eyes.
Yeah,
So that is a fake case. That's our macular hole post-op. So I have music in the OR, and what's playing at the time is All I Do Is Win. You know that song? Go ahead, Peter. Go ahead, sing it.
Don't know it.
Nope. How do you not know that song? All right, your hands go up and they stay there. So as I'm doing this case,
Does not look good.
it does not vitreous hemorrhage, subretinal hemorrhage, lots of hemorrhage. So I took multiple biopsies. I decided since there was subretinal hemorrhage, I wasn't going to do anything else. I got out of the eye. So I saw vitreous hemorrhage, subretinal hemorrhage, exudative RD. And so then I asked my fellow, who at that time was there, Dante's and Nathan's partner, because they looked ischemic to me, and I said, what do you think, Dilsher? So I saw this could be toxo, this could be lymphoma, and Dilsher, states that in his vast experience, it looks like end-stage toxo. I've never seen lymphoma do this. And
Did he ever see lymphoma?
Yeah, he didn't actually know how to spell lymphoma, so that's all right. So it's all good. So here's the answer. Biopsy wrote toxo PCR is negative. Cytology initially was negative, but the flow was positive for lymphoma. So I said to the pathologist, hey, look at the slide again. And like, oh yeah, actually I do see lymphoma. So the question is, was that subdural actually true? So they actually ended up doing a dural drain and a biopsy, and everything was negative. So he had an enucleation done because the eye became painful and ischemic. So I just wanted to share with you the past.
And the other eye was fine, though.
Other eye was fine. I actually do look at the other eye.
All right, so let's take a vote now. Who thinks that this is a BS case? Raise your hand.
I would raise your hand.
Raise your hand if you think this is
This is a
fake case.
Peter Kaiser macular hole case. That's what I'm telling you.
I fixed the other eye.
This is a real case.
This is a donor.
So no one was fooled on this one.
This was no one. This is there because everyone in the audience is smart. All right, so here's the past specimen, that my favorite part of the whole case, which eventually I'll show you. All right, it's a long thing. Infiltration of the retina, optic nerve, central retinal vessel, and in the choroid and vitreous. That's why the patient became ischemic. Consistent with diffuse large B-cell lymphoma. And my favorite line of the whole thing, correlation with clinical findings is suggested, which is pretty easy to do when you have an enucleated eye. So this is how Nathan actually learned to do clinical correlations. He just takes the eye out. So that's always good. So the lesson here is lab tests can sometimes lead you down a path, and clinical correlation is always easier with an enucleated specimen. That's my case.
Any comments or questions from the audience?
There was nothing wrong with him. The choroid was normal. Everything is normal on the other eye. Nothing.
Everything's normal on the other eye.
How
Lucky
could that
for
be?
him.
Because that sometimes lymphoma presents as a unilateral case. It'll be asymmetric. It doesn't mean that you don't treat them systemically. So he still got systemic treatment for his lymphoma, because that's how we treat these patients. And but his other eye is completely normal. There was a question or comment. Yeah, go ahead.
Why do you think things look worse after the PSTK, or just between like your first and
Yeah, so lymphoma sometimes will respond very nicely to steroids, but there are some patients who actually will have a negative response to steroids and actually get worse. And I just think this patient had a very, very advanced case that you can actually, some of the lymphoma cases I actually do see will have a pretty significant inflammatory reaction. So I just think in this patient, there was so much tumor in the eye that they weren't going to actually respond very well. Yeah. So the question is, would the patient have done better if they, or done differently if they got external
You
beam
had actually made the correct diagnosis.
in the beginning? You know, it's a fair point. You know, could we have saved the eye? I will tell you that the eye looked, if you look at the pictures going back even to the first picture, there was already hemorrhage forming in the eye. So I do think external beam probably would have saved the eye. This is right on the nerve. This is an NLP eye, probably in the long haul. And in these scenarios, unless you get to them really soon, I do think unfortunately you can lose it just because they become ischemic. This is one of the few that I've ever enucleated, and this was in a scenario that the eye became ischemic. But your point's well taken. If the diagnosis was made earlier on, we could have saved the eye.
How long was the referring doctor following the patient and treating before they sent to you?
18 months.
How about this question?
So pictures?
Do I have pictures?
Earlier from the 18 months ago or 12 months ago.
No, because not all referring docs send pictures because they don't want to show you what you have. But I had one picture just from 3 weeks prior. I didn't get anything before it. But reading the notes, we had an eye that was seeing 20/40 18 months ago.
So if the patient fell and got a subdural hematoma, any chance that's Terson syndrome on top of lymphoma?
But the patient fell after, right? Oh, so you're asking about the vitreous hemorrhage?
'cause it got-
Yeah, it's a fair point. It could have been. That would have been a really nice.
Yeah, you could have said it
right.
was Terson's and Toxo, but you missed that.
I
missed that one.
I was really suspicious. I really thought, this one bugged me for a while because, when the Clin didn't work, I was like, well, I think this is lymphoma and I want to get in this eye. And then when I couldn't get in it because of the subdural, I was just worried. So I was following MRIs, waiting for that blood to settle. Anesthesia was not comfortable.
Don't worry, don't worry, you're okay.
I worry about everything. I worry about Peter's post-ops. That's the kind of guy I am. Have you seen his post-ops?
That's why he sleeps so well at night. Nothing to worry about.
This is true. He doesn't operate anymore. Yeah, go ahead. Hey, Mark, how are you?
Good. Did this patient have, where was they had vitreous hemorrhage, was there extensive subretinal hemorrhage as well?
Yeah, absolutely. Yeah, it's subretinal hemorrhage. Not the first time I saw them, but if you
Right.
saw in the ultrasound, they started to develop, and then certainly when I got into the case, there was subretinal hemorrhage.
So I've seen a lot of lymphoma, and I've never seen massive bleeding. from
First
it.
time I saw it, but now I've seen, so Arun Singh, who's our ocular oncologist, I actually asked him, I said, have you ever seen this? And I've actually called a bunch of my friends who do a fair amount of lymphoma, and they've all said, in the worst case ischemic eye, but maybe one in their career that they've seen. So this is a very weird presentation.
But this guy did have the subdural as well, so who knows?
True, but again, if you go back to that second image, he had hemorrhage already starting, and that's the thing that threw me off because I was thinking exactly what you were thinking, Mark. That how often do you see subretinal hemorrhage with lymphoma? I mean, it's really odd. I've seen subretinal hemorrhage in toxo, like in a really, and again, ischemia and toxo is not that uncommon, especially if you've gotten a lot of steroid because just the toxo spreads so much. So I thought I was coming into a toxo eye, and then I looked at it, I was like, this is like nothing I've ever seen. So again, the other lesson is if you're going to go in the eye, get a good biopsy, send off the specimens, make sure you do it correctly. Nathan, when he was my fellow, and you'd ask him to send specimens, he'd stop at Starbucks, go get a Moe's, they'd be in his back
Chat with the
pocket.
nurses a
So
little
everybody
while.
had no lymphoma. Nobody had lymphoma when Nathan was there, at least until he left.